You're tuned in to RX Radio.
What you got there?
So this is coffee. It's just black coffee.
Okay.
But
Cup is
I
awful small for you.
I know, man. This cup's like half full. Like, can you even?
Yeah,
Yeah,
barely.
it's terrible. But this is just a countdown of days until we open up the podcast. I'm just sitting here with a cigarette in my mouth and I just light it.
See, that's interesting because my brain immediately when you went to that hand gesture was just smoking straight boulders. Like my brain was literally just like glass pipes and light bulbs and shit.
Yeah, that'll be like a progression of less than a month for me. It's like I start cigarettes. It's like, let me try meth.
Yeah, that was creatine for steroids for me. Well, that took
uh,
about that took about half a tub before I was like, wait a minute, you're telling me that this stuff over here? Okay, yeah, hold on, let me grab the needle.
yeah. No, mine are going
Yeah,
IV if I get on the needle.
really.
Oh, dude, I'll bet heroin's so good.
Let me go ask literally anyone right outside my building.
Yeah, there's no way they would be leaning that way if it wasn't.
Yeah, dude, the fucking human origami that people fucking bend themselves into on fucking heroin and fentanyl is wild. One guy was a crane, I was like a folded paper crane. Literally, it was wild, and I no idea how he did it. It was just literally this paper crane on fucking Market Street. Which brings us to today's topic. No, like as a chiropractor, you look at that and you go, "You have a spine, right? Does fentanyl
Yeah.
eat your spine? Like how? Like what is the biomechanics of turning yourself into a paper crane in the middle of the Tenderloin district?" It's yeah, it's wild. It's funny. I've had a lot of chiros who came into the podcast are now graduating. So I've had like a bunch of people. Isaac from Logan, who's in level 2 right now, just finished. So if all you chiros out there, it gets way better. Louis C.K. does a joke about being a fat kid, and it's a lot like being in chiropractic college. Like, trust me, like he's like, look, if you just are employed for like in your 40s, your life just gets way better. And it's just like he's like, I wish someone told me that when I was in high school as like a fat kid, how good life can get. And it's like chiropractic college is like the fat kid of academia. It's like, look, if you just stay in it and like don't do anything crazy and just like stay employed, like your life can get way, way, way better. Now, not to say it can't get worse, but the option for it to get better is there. And I think, I mean, for when we finished school, it didn't seem like that was the case. But here we
No.
are, what, almost
No.
10 years? Are we 10 years out?
Yeah. We graduated, what,
Yeah.
25?
What?
That's
December
nuts.
14th, 2025?
Decade.
That's fucking crazy. And then the
It's
company will
wild.
be 10, Prescript will be 10 years next year, next November,
Yeah.
26, November 26. That's insane.
That's
Gets
nuts,
better,
man.
kids. It gets better. And I feel like a type of way now addressing people as kids, but it's like 10 years younger than us. Like, yeah, you got a fun 10 years ahead. And let us try and expedite some of the pains you're going to run into with today's episode. Today, what are we doing? We're doing understanding low back pain.
Low back pain, yeah.
Yeah. And I think
Yeah.
it's obviously as chiropractors, it's just you know what it is? It's really two things. I think about chiropractic a lot in the way it swades biases. And I think the bias that it swades the most is how you communicate, right? Like, I think that's where a lot of people get really, they get raked over the coals on social media is because they're just not properly trained in how to communicate what they know and how they're going to apply that knowledge to a person. They just don't know how the rest of the world interprets it because you get out of grad school you get out of undergrad and you end up in this stovepipe that like echoes really weird science and philosophy and the art. Here's something I want to call attention to. Anytime something is considered to be artful, whether it's like art itself, like paintings and shit like that, or sport, or coaching or training or chiropractic, like the art of insert discipline. The art means two things. It's the communication and application of the philosophy and the science, right? But let's dig a little bit deeper. What is philosophy? Philosophy is the science of the question, and science is the study of the answer, right? That's really how those two things come together. And the art is the communication of the question and the answer, right? And that's true of like paintings. Like, what is the question? What is the answer? It's like you can see art Like I listened to a podcast the other day. I think it was an Alex O'Connor podcast, and he had this guy on to talk about art, and he kind of framed it in a similar fashion, just like paintings and pictures and all this shit. And he was like, art can be good, but answer the wrong question, right? So like you could have, and this is fucking super morose, but like you can have a very good drawing of Adolf Hitler, right? Now, the question is bad, but the answer, what you're getting, is still good. It's just not a good question to begin with, right? Right. Like if we can kind of extend out that metaphor. And I think where people get tripped up in low back pain, especially chiropractors, is they just don't know how to communicate, right? They know, I think, to a certain degree, the application, right? And if I had to kind of complete the analogy, it's like art is the coming together of maybe philosophy, science, and experience, where the philosophy helps us shape good questions, the science helps us find good answers, and the experience helps us apply the truth. And I think that's like how these things come together. And I think they just lack that last piece. Like, you come out of school, you don't have the experience, and you don't really know how to apply the truth to someone or find the truth through application of the good question and the good answer. So before we go on any further, PSL 1 starts May 12th. It is accredited for CEUs through PACE. So if you're a chiropractor that your state or if you're from Nova Scotia, PACE also covers the province of Nova Scotia in Canada. So if you're a Nova Scotia chiropractor, or you're a chiropractor covered in like the 26 states covered by PACE in America, PSL 1 is covered for your CEUs online. So if you're looking for just not the dog shit option that's out there for literally every other CEU course provider that we've ever had to take, PSL 1 is registering now. So go to www.pre-script.com and PSL 1 is on the homepage. Now, low back pain. Where do you start?
Yeah, no, I like the art analogy that you started out with, and like even to run with that, like I agree 100% with what you're saying, and I think where I was coming out of chiropractic school and getting into practice was very much I had the full palette of colors. I had all of the brushes, all of the pencils, the ink, whatever implements that an artist is going to use. And if we look at the patient as the canvas, I had no idea how to put these things on the canvas, right? There's just all these ideas floating around in my head of, okay, like I feel like we were very good at diagnostics getting out of school, like with the man himself, Souza. I still have the book in my office, but like understanding how to diagnose and think critically about what someone's experiencing based off of an exam and a history, understanding how to do specific treatments, but then not understanding how to apply a treatment to a diagnosis and do so in a way that allows a positive outcome. Right? That was the big disconnect for me when I got out of school, and that was the experience that I was missing. So like understanding low back pain there's layers to it. Is that yes, you need to understand the pain and the injury and the reason this person is coming to you. But then there's also that application aspect of, all right, even if I do understand everything, do I have the ability to take that understanding and turn it into a positive outcome? And I think that's where a lot of people miss with this, is that they're taught a bunch of different tools in terms of treatment. Like I know how to do a side posture adjustment. I know how to do ART on a QL. I know how to do McGill's Big Three. Great. Like 3 different treatments that are going to address 3 different systems, 3 different issues. What does that look like over the course of a week? Like you treat someone, they feel better, and then at the end of the treatment, they ask you, what do I do next? What do I do tomorrow, the next day? What do I do for the next week? And some people just don't know. Or sometimes that answer is it's built out of ignorance, and it's built out of culture, and it's also built out of the need to make a living, where it's like, come on in 2 to 3 days and we'll do the same thing again. And we'll do that for 4 weeks, and then we'll do that twice a week for 4 weeks, and then we'll do once a week until you die. And it's building this dependency model that I think is to be blunt about it, I think that's malpractice. I think that's very ignorant. It's very short-sighted. It's fear-mongering. It's taking someone's lack of understanding around the musculoskeletal system, injury, healing, pain, and profiting off of that, which, you know, maybe that's me being a bit virtuous, but that's a lot of what the healthcare system is. The healthcare system doesn't profit off of healthy people, right? It profits off of people that stay sick. Like, why do you think there's a big discussion around how much insulin costs? It's because people need it to live. And if they want to keep living, then you can keep profiting off of them, right? If you're one of the people that profits off of insulin. And it's kind of the same dependency relationship that I think a lot of people are, out of ignorance and necessity, forced to have as they come out of school as a chiropractor, because they don't know what to tell someone what to do so that they can have an improvement in low back pain in the time that you're not giving them a side posture adjustment. So I think that's a big piece of this, is that there's a lack of understanding in the hard skills that it takes to pass the test, to get your expensive diploma, to become insured, to have a business license and practice as a chiropractor, and the actual skills that it takes to apply that knowledge to get someone to have positive outcomes with treatment. And that's the first thing that it took for me to understand before I could actually have any sort of progress in that area, because it's like, all right, I need to be aware. I need to realize that this is something I don't fucking know how to do. Like, I'm completely ignorant to this process before I can now dive in and be like, all right, what do I need to do to learn this? And that's, I mean, a little bit more on the philosophical side, but like understanding that this isn't just it's not just pigeonholed to the one skill that you have, right? If the one tool I have is a hammer, everything looks like a nail, and that's chiropractors to a T, right? I've heard chiropractors talk about, oh no, I don't do muscle work, I just do adjustments. And that's insane to me, because right, if you were the sole thing that moved their bones, then they wouldn't need muscles, but their muscles are moving their bones 100% of the time. So it's like these two things don't exist in a vacuum. It's not just skeletal system, it's not muscular system, it's the musculoskeletal system. So I think a big part of that is like the philosophy side of chiropractic. There's a lot of these very very focused in tunnel vision practices or systems that just completely ignore the way that the body works. So all of that with like an understanding is like, all right, none of these things are probably 100% right, but there's probably truths that I can pull from these things. And one of the biggest things that I think accelerated my chiropractic career, my understanding of how people get out of pain, is strength training. Is that even if I don't know, to this day, if I don't know what the fuck's going wrong with someone, I'll just take them through an assessment and I'll see where they have really shitty ability to produce force or a strength discrepancy, range of motion discrepancy. I'm like, oh, all right, let's just fix this specific thing and see how the symptoms result. And I don't know, close to 100% of the time, it works. Even if I don't know what the fuck I'm doing, there is a result to be had there.
Yeah, I think it all starts with a level of humility. And it's like one of I think the difficult part for students turning to practitioners, or when it comes to communicating low back pain, and this is worthwhile if you're even a patient. Like, this is, not everyone listens to chiropractors, but most people are coaches or they're just enthusiasts. So I want you to see this through whatever lens you're filtering this podcast through. That when you leave school, the school is in the business of providing you with some level of certainty, right? That's what the transaction is, right?
Mm-hmm.
You go in and you pay them a small fortune to which you're indebted for the majority of your life. And they have a hard time turning around and telling you that the story that you're paying for is incomplete. So they don't do that. They go, this is it. This is, it's like, what's the Mormon guy, Adam Smith or whatever the fuck his name is. And they have, like, chiropractic is basically like the translated Egyptian gold tablets that started Mormonism. And they're just like, yeah, this is the whole story right here. And we translated it for you, so only you guys know the holy word. And you're evangelized in this system. And look, every healthcare denomination has this evangelizing process to it, right? You're an MD, you're an osteo, you're the further left of center, alternative of center you get, like, we look at Reiki healers and we go, say what? But like an MD looks at us and goes, say what? And we're just kind of like, all right, like, let's try and be critical and have an ounce of humility. And I think if you can do that from a top down level in the way you get educated, and you can do that in the way that you educate, you go from having a transaction to having a relationship. And I think that's where I've learned the most. Like when I learned at school, it's like, and I did this in a less than tactful way. You were in class with me. I was critical to the point of, almost getting thrown out of school, where it's like, can someone level with us, please? Like, I have a finger up an ass of a fake dummy.
Oh my God.
What are we doing here? And there were teachers that were like, yo, dog, this is crazy. And I had a good relationship with them, and I learned so much from those people. But you had other people who were just like, no humility, which kept a wall up. They were like, no, this is the gospel as according to D.D. Palmer. And you're like, what the fuck, dude? Can I have a conversation with a person, like a real person that isn't just brainwashed by this shit?
Yeah.
And for those people, I didn't learn anything from them. Right. I learned how to pass a test. Sure. But all the teachers that I had a great relationship with, I was able to learn so much from. And I learned from them because of their humility, because they took down this wall. And one of the things, the meta skill that I learned outside of, sharing in their clinical experience, learning how they've had success in practice because I had a relationship with them, I learned that was how people learned. And I was like, okay, if I'm going to teach my patients, clients, whatever, I need to establish a relationship with them. And the way that the relationship starts is with humility. Like, I'm not a super religious person, but there's a quote, I think it's actually from the Torah, and it goes, wisdom begins with the fear of the Lord. And it's like, a bit heavy. That's like Old Testament shit. But it's like, okay, right. There's like, I am not the be all end all here. And that's how you start forming a relationship. And I think it's so, you don't know what, I mean, at least for me, I graduated, I didn't know what side of the bed to piss on. Like, I was fucking terrified. And it's like, when you just, you stop trying to front and you just go like, look, like you said, I got no fucking idea how you've done this.
Yeah.
I know that you can deadlift 900 pounds, but you can't seem to do this. I'm not saying that this is the cause. I'm saying I don't know what the fuck's going on. Let's just see if we get this stronger, this doesn't start to move the needle. Like, I think we could all agree. And this is like where I started to catch heat for if you can't stand on one leg, you shouldn't squat with two axiom that I sort of coined back early days L1. It's like, look, I don't know if these two things are correlated, but to your point, as I get people better at the simple task of standing on one leg, all of a sudden their pain when lifting with two starts to dissipate. And my only thesis was, I have no fucking idea. But two, it seems a little odd that with two legs you can squat 900 pounds and you can't control your body weight on one leg. Like, it just, to me, call me crazy. And that it starts in that humility of like, I have no fucking idea.
Yeah.
Immediately opens the door to a relationship. And that's where I think that's like, not the beginning and the end. Otherwise the podcast would be fucking whatever, 20 minutes. But I think so much of, what people know is lost. It's useless. It's not applied because they can't take their, I don't know, I guess ego maybe would be the right term, and put it aside and build a relationship. Like, dude, I have such good like relationships, friendships with every single one of my patients, and that's correlated to the outcome. Right. Yeah. Like, that allows you to, when you say, I don't know, then when you start to maybe even get a hint of something where you're like, okay, I'm pretty sure, the weight behind your pretty sure is so, there's so much trust in that, because you started with like, hey, we're in this together. I don't fucking know, but this is what I'm seeing. Let's try this. And it's really about gaining territory in the land of trust to build a relationship first. Then you can communicate, then you can start getting results. But man, like just the defensive nature. And hey, look, I think one thing that, again, if we're talking mostly to chiropractic students here, the promised land isn't when the tassel goes dude, like that's not even close. That's the beginning of round 2. That's like, okay, Shawshank Redemption, have you seen it? Yeah, all time. If you haven't seen Shawshank Redemption, fucking get a life, go watch it. Shawshank Redemption, the Andy Dufresne spends the latter half of the movie tunneling his way out of Shawshank with a rock hammer, and in serving his time, he chips away in this tunnel. Chiropractic school is breaking free of the wall. Your first couple of years in practice is the 200-meter sewer pipe full of shit you need to army crawl through. You do that for 2 years or 3 years. In our case, it was probably 5. I don't know. When did stuff like stop sucking for you? 2020?
Yeah, it was probably like 5 to 6. Like 2020 was a rough year for us, man. Yeah. 2021 things started to look up. So I'm thinking like about 6 years, which is like a crazy amount of time because I don't know. I'm sure you remember this. Is like the statistic of 50% of chiropractors will not be practicing within 5 years of graduating.
Yo, they told us that on the first day of school. Do you remember that shit?
Yeah, dude. I wish I was less ignorant and I just like saw the writing on the wall at that time. Like,
dip
this
out.
Isn't for me.
See you later. I literally remember it was who the fuck was our was it Meeker? No, who the fuck
DeMontier?
Was it? Yeah, it was DeMontier. The only people I remember in that entire room of like, I don't know, 50 kids was you and Tyler Dickinson, because I'm like, yo, these guys are kind of jacked. Like, I don't know how am I going to be the most jacked guy in here with this cauliflower eared fuck like eyeing me up. And it's just like, yeah, and I think there's maybe something to that 5-year mark, but it's like if you want to delay gratification, if you want to build a practice based off integrity, if you want to build relationships and ultimately be able to get results, that honesty, that transparency, that humility, that starts to pay back in interest after 5 years.
Yeah.
Right? Because I know people who are 20 years in who, they put on the suit and they get in the Lexus, and then when they get to their work, they put on the scrubs and they walk. Like, dude, you're not, stop it. Like, just, what are you doing, man? You're sitting there with the golden tablets telling everyone that the word of God says you want to fuck everyone's wife. Like, what the fuck are you doing? You're not going to have a relationship with anyone. And at the end of the day, like, that's what's going to drive clinical outcomes. I read a book while I was in chiropractic. It was very, at the time, it was very, I don't know, disheartening, maybe the right word. I think it was called Stabbed in the Back by a physician named Norton Hadler. A very dispassionate analysis of the research on low back pain. And it was, I don't want to say pessimistic, but if you read it as a chiropractor, you would look at it as pessimistic. But it was really just like his narrative summary of like, look, we don't fucking know. Like, we don't know. It's so prevalent. We have no idea. And here are all these interventions, here are all these meta-analyses, and nothing seems to be better than anything else when it comes to beating sort of the natural outcomes of this thing. And, at first I read that and I was like, fuck this guy. Like, he's just a stupid MD. And I was like, oh no, I'm being evangelized by the institution, by the Church of Chiropractic. Right. And I'm just like, I can't let that happen, because if I have a successful practice, I need to be able to communicate with MDs. My sister's an MD. Right? So I can't come in and just be like, well, the innate isn't flowing. It's like, dude, like, I'm here to spread the good word. Am I going door to door with this shit? Like, I don't want to be fucking, getting chased off people's lawns and fucking, like, I don't miss me with all that. So I was like, okay, I need to be able to synthesize this book. And from there, I kind of like gained a bit of humility, and it's like, yeah, I don't fucking know. I don't know. And, when you look at evidence-based, which is something I've talked a lot about recently, it does hold up on 3 things. Right? It's like a milk stool, and it has these 3 legs to it. It has it has the best practice research, which, like, let me tell you, it's all a crapshoot. it's all a crapshoot, right? Like, you got Coca-Cola funding sugar studies back in like the fucking 70s or whatever. Like, you can go to, Bill Burr does joke about this. He's like, you can go to www.imright.com or whatever and just like find whatever research backs your claim. So then what are you left with? You're left with the preferences of the person you're working with, and you're left with your experience. So when you're just starting out in practice, you're left with your experience, to which you have none. So you're really left there with your dick in your hand. And then, so what do you have left? It's like you have the person. And it's like, great, I need to lean into this, and I need to get as much out of this person as I can. And how are you going to do that but forming a relationship? And that's going to be based off of trust. And that trust is going to start with the humility of going like, I don't know, but let's figure it out.
Yeah, I love it. And the thing is, like, those are the relationships that are worth building. It's one based on trust, not one based on dependency, fear mongering. It just shows two completely different clientele. And like, I'd be willing to bet that someone that has the humility and the confidence to admit when they're wrong, they have a lot more gratification in their day-to-day work than, insert 55 to 65-year-old chiropractor getting in his Lexus to put on scrubs. That, I'm sure that's a lot less gratifying day to day because of the type of people that you have to deal with, because you've now built this dependency, right? And that's just like it's just a grim outlook for everyone involved. Like, yeah, all right, you'll make your Lexus payment and buy a boat and like put your kid through college, I guess. But like, at the same time, are you really helping anyone? And deep down inside, you have to fucking know that. You have to know that you're a fucking fraud. And that's something that, like, I'm not going to be able to sleep at night, and that I'm not going to put myself in a position to build a business on that as a crutch. So I don't know. Aside from that, I think these are some of the maybe underlying thought processes and like the early on realizations that first you need to know that you know nothing and you don't have that experience before you can dive into this and you can really solve that. But to me, like, I hinted towards this earlier on, is like the thing that allowed me to solve a lot of problems clinically was leaning on my training experience. And that's, yes, for myself, but also for other people. Because in training people, like, it is very much, it's a similar, if we were to look at the cross section of trainers, it's a similar idea in terms of people that have different virtues around different things, or kind of the clientele that they take on and the way that they operate that relationship. Is it more trust or dependency based? But if that's something that you're able to see a high level of success and you're able to build those relationships, it gives you that freedom to have a lot of trial and error. And that's what practice is. Like, literally, it's called fucking practice. You're just practicing this skill day after day. So understanding that, like, look, if you're transparent, you build that relationship out of trust, it then gives you the freedom to be confident in the things that are working and the things that are not working. It's not like you have to have this kind of veil of, oh yeah, this is exactly what I intended to do, and we're just going to do this for another 40 years until your insurance won't pay. Like, that's and I mean, that's a red flag in itself. If someone's like building treatment plans based off of what your insurance will pay out, that's and maybe a whole other conversation of like private versus, the healthcare system. But when it comes to actually intervening with and understanding low back pain, to me, there's a few things like this. We have to understand, or at least have a good working diagnosis of what's going on, right? Is do we know, can we take a history, understand the mechanism of injury? And from the mechanism, are we going to be able to extrapolate what's actually going on there? And I'll kind of break it into three different categories in my mind. Is this more mechanical, inflammatory, or is this actual tissue damage? And if we can put it in one of those three bins, then it allows us to start to understand, like, all right, if this is mechanical, this is purely because of how you're moving. So maybe pain that is more positional. Like, I feel it when I do X, Y, and Z, but not when I do ABC, whatever that might be. Inflammatory is they're typically things that are I'm sorry. So that mechanical pain is probably going to be more positional, and they're not going to feel it outside of that position. Inflammatory, they're probably going to feel once they flare it up, once they do think that is that aggravated, it's probably going to linger, and it's probably going to be a little bit transient in that sense. And then tissue damage is just it's not going to feel good until that tissue is healed, right? So that's like one filtering criteria that I'll use to look at low back pain or back pain in general. Like, all right, which one of these does it fit into? And then I know, like, mechanical pain, all right, this is something we just need to change their movement pattern, because when they're not in the positions that aggravate it, they're not going to feel it. Inflammatory, we need to understand, all right, this is why it's flared up, probably because of repetitive stress, or also probably a movement pattern that they're stressing specific structures more than they should be. So again, we need to change the way they're moving, the way they perceive movement around this area. And then tissue damage, I need to allow them time for this to heal. So it's similar in ways. It kind of branches off that, okay, if tissue's damaged, this is going to be a different treatment than these two. If it's either of these two, then it's going to be a little bit more of a learning process. Mechanical pain, probably something that's less chronic, or something that, hasn't had the time to develop into inflammatory. So that might be a little bit quicker treatment plan or treatment protocol than something that is already inflamed. And then from there, just kind of taking steps to filter more and more and more, is that the more you understand the nature of the injury, the nature of the pain that they're feeling, then that just allows you to be more accurate in the treatment that you're assigning to that person. And that's like filtering criteria number one for me.
I think there's one of the things, and I feel like we're somehow and we're talking to like early clinicians, but I think I'm going to try and frame this in a way where a clinician can understand how to impart this on a patient, but a patient should be able to go to a clinician and get this specific data point. Because one of the things that I struggled with early was, and I see this with coaching as well, is giving nothing and actually taking stuff away.
Yeah.
And I think that's where I think there's one of my favorite quotes of all time is beauty is the purgation of superfluidities, which is like, what the fuck does that mean? It's basically like, think of Michelangelo's David was just a giant piece of marble. And we whittled down to this sculpture that was already there. We didn't build it up. It's not like we took a bunch of clay and made it. That was within the thing already. So it was actually the reduction to this final piece. And I feel like treatment is very similar, where, beauty's in the purgation of superfluidities. It's like, there's a superfluous amount of stuff here, and we actually need to take some stuff away. And I think one of the things that a clinician needs to do is, and you're so, when you're in this transactional mindset of they're paying, so I need to give. No. They're paying for a result. And a lot of what you need to give in cases of low back pain, especially, is you actually need to start taking away. You go, okay, hold on. What is your whole workout routine? This is where I start. I was dealing with a shoulder labrum the other day, and I was like, give me every exercise that you do. And then I was like, oh, okay. How do you perform all of these movements? And I watch and I go, I could give you insert evidence-based rehab, long-term, short-term outcome exercise, whatever. But if you keep doing your row that way, your bench that way, your pull-up that way, I'm doing nothing. I'm throwing Band-Aids at a house fire. Like, it's just like, there's no amount of, so I actually need to go like, hey, either stop doing that or modify this. And it's taking this giant thing that has been, ill polished and ill carved, and trying to fine tune it and polish it. And there's a nuance and there's a flexibility and there's a meeting them where they're at. Cause like, you can give and give and give and give and give, but you're trying to pile on and pile on and pile on. It's like, there's already stress at the shoulder. And this is, a cornerstone of what we talk about in L1. It's like an injury or pain and injury. That's a podcast in itself, but applied force greater than tissue tolerance. Let's not just worry about giving exercise to improve tissue tolerance. Let's take an inventory of how we're applying force to the region, in this case, the low back. But the principle stands across any region of the body that you're trying to manage. And it's like, beauty's in the purgation of superfluidities. If you're trying to really make an impact and give, a lot of times you're going to give on where to take, right? And because something about what they're doing, and pain is very multifactorial and this, that, and the third, but it's like, if we're going to have an intervention at all and not be treatment nihilists, which so many kids come out of school these days, and they're just these, weird, angsty, like, fuck you, mom practitioners. And you're like, okay, dog, like, good luck. Good luck making angry reels forever about stuff and no one wanting to come see you and never being able to build a relationship that's ultimately going to help someone out. But it's like, you know, you got to think in that mindset. You got to think, and I literally think that is the first filter that I apply is what led you here and what do I need to come in and take away before I start, you know, doling out the goods. A lot of what I'm doing in most cases is that purgation, is like, clearly before you dawned my doorstep, there was something that was amiss. And look, these things happen. And sometimes I look at programs and I look at execution and I go, it seems balanced. Execution seems good. Then it's off into the ether. But I would say, you know, 99 to 100% of the time, I'm finding something that's like, you know, my corrective exercise intervention is a drop in the ocean compared to this tidal wave of just aberrant mechanics and improper loading. So start with that. Start with this nuanced, this approach of going like, hey, what do we need to fix? How do we solve this problem from reduce? Like, how do you squat? How do you deadlift? Because a bird dog, a curl up, McKenzie method, whatever, deflection, distraction, all of your things are drops in the ocean.
Mm-hmm.
And then these movements that have loaded them into these positions, if not corrected for, if not taken away from, are just these massive waves crashing against the structures and tissues in the body. And it's like, you're a drop in the ocean, dude.
Yeah.
Right. So there's a confidence you have to have in what you know, which again, like, isn't a lot, but we talked about this in the other episode, is more than them, that goes, hey, let's try and peel back, right? Purgation, or beauty is the purgation of superfluities. Like, you're doing too much. Let's try and either do less or do different.
Yeah, absolutely. And the undertone of all of this in my mind is like, these things happen out of ignorance on whoever's coming to you on their side. They didn't know that the way they were rowing was going to flare up their shoulder. They had no idea that an overhead press could hurt their low back. It's like, no, that's a shoulder movement. Why would that hurt my low back? Like, it doesn't, it's not the same. And do you still have gravity in a low back around you when you're shoulder pressing? Like, so to me, it's very much a learning and a teaching process, right? The first step to successful rehab is building awareness around what the problem is. And the problem is them 100% of the time. But more seriously, is the problem is that people don't understand how an overhead press can cause low back pain. And like, if you extrapolate and you pull from that, it's like people don't understand how to use a shoulder independent of a spine. So people need to learn that, you know, rehab processes. If I see someone that hurt their back doing an overhead press, it's like, oh, this makes my job really easy. I need to teach you how to protect your lumbar spine and still use your shoulder. Like, I know how to do those things. Like, and those are very scalable things. And that's, you know, responsible exercise progression is getting people to understand how to use specific body regions independent of others, right? The dissociation of lumbar spine and overhead press. That's what we need to get them to learn. And it starts as, at first, building awareness is like, no, this is exactly why you hurt your low back. And then it's kind of honing that in and teaching them. It's a learning process that you need them to learn. Like, all right, this is the position that I need to be in my lumbar spine. And maybe, you know, maybe they're seated, maybe they're standing, maybe it's something that really comes down to foot pressure. Maybe this is, you know, maybe they had an ankle sprain and that's why they hurt their back doing a standing shoulder overhead press. It's like, yo, mind fucking blown. Like, my ankle thing caused my low back thing doing an overhead thing. Like, that's so hard for people to understand, but they're so common that things like this happen. Like, I'll be taking a history on a patient and they'll come in, say, for a low back thing, and I'll ask, like, have you had any other surgeries, injuries, X, Y, and Z? It's like, no, not really. I'm like, okay, like, any injuries, like hips, knees, ankles? It's like, oh yeah, I had an ACL replaced 2 years ago, but I didn't think that mattered. I'm like, wait, the thing where you were in like a wheelchair and you were immobilized for like 6-8 weeks, like, you didn't think that mattered with your low back? So it's, first and foremost, is there needs to be a level of awareness of how, this thing isn't happening in isolation, and it's probably happening directly as a result of something that they're doing that they're not aware of. So go ahead.
No, what I love about this, and I've been kind of chomping at the bit, because this solves clinicians' problems with buy-in, because what you're describing are the two components of motivation.
Mm,
And I think what treatment plans so often lack, and what you've kind of highlighted there, is so motivation comes down to two components. We need to be moving away from something. It's the carrot and the stick, and it's both. We need to be
mhm,
moving away from something while simultaneously being drawn towards something that so away from something we don't want and towards something we want. That's motivation.
mhm.
Those are the fundamental tenets of being motivated into action. And what a lot of times they miss is that foundation that you like. What are we moving away from? Right. That's the thing that, like, when I'm not in the office, this is okay. I need to be mindful of, when I'm turning in the backseat to smack my kids. It's like, well, hold on. Too much trunk rotation. You just fucking sneezed out a rib. Like, let's calm down. Oh, okay. All right. Square my shoulders up and then fucking hit the kid in the back or whatever it is. You know what I mean? And it's like, we need to create that awareness on either end of motivation.
Mhm.
That is buy-in. When people come up with this nebulous idea or this issue in their clinic of like, I really have a hard time getting buy-in. And this is a coach thing and a clinician thing. It's like, well, you haven't done a good enough job at communicating what it is they need to move away from and why, and what it is they need to move towards and why.
Mhm.
Right. So there's something amiss in this equation, because if you do both of those effectively, you've effectively motivated that person into action.
Mhm.
Right. And that is essentially what people refer to as buy-in. That's what they're buying into. They're buying into the process of being motivated, of moving away from an undesired state and moving towards a desired state. And then your guidance through this is the value you provide to them as a clinician, and they're always going to come back to you, right?
Yeah.
Whether it's a year, whether it's 2 years, whether it's 6 months, whether it's the next injury, it's going to be they are going to understand a lot of times just subconsciously. Sometimes people are aware and can put these things together, but regardless, they are going to feel motivated in the presence of your course of care. And you need to understand the tenets of motivation are those two things. Okay, we're going to, like you said, identify the problem. What are we moving away from? And then let's identify this. And look, sometimes it starts with the, hey, look, I don't know, but
Mhm.
the problem is you can't stand on one leg, right? Your left arm can't get here. The solution is, let's just aim at that and see what happens. And that is such a motivating, that not even that is such a motivate, that is motivation, hard stop. So in your, whether it's coaching, whether it's treating, whether you're a clinician, whether you're a coach, whatever, you need to identify those two things very clearly, because that is the pretext to buy in, right? Whether that's the actual financial investment or whatever, if you're having a consultation, that's your straight line
Yeah.
to getting buy-in, is to get them motivated by identifying those two things. And so many people, when I talk to them about, when we're in labs and I'm talking to coaches and clinicians and issues they have, okay, it's 99 to 100% of the time, you're missing one side of that equation, right?
Mhm.
You're just not able to motivate people because you're missing either a clear identification of what you think they need to move away from, or you're missing, where is that location set on the Google map in the direction of your treatment plan or course of care. And you draw that straight line for them, they're motivated.
Yeah. I love the map analogy as well, because this is why they come into you, is to navigate this, like literally to navigate this. And they have these 2 points in their head. Is like, I'm in pain, I want to be out of pain. And they have no idea what's in between. So it's literally you just drawing that on a map. Is like you're mapping out what they need to do, and by defining what they need to move away from and what they need to move towards. And that's exactly it. And it's like you said, that it takes confidence, it takes humility to be like, I don't know exactly, but I know these things. And this is a conversation I'll have like almost verbatim with people. Is like, I don't know exactly what's going on with you, but I am seeing a lot of muscle spasm. I'm seeing an asymmetry from right to left. And I can guarantee you that those things are either contributing to that pain or a result of that pain. So if we take care of this and this, it's going to have an effect on the sensations in that area, period. I'm not making any promises. It's all very vague, but I am relating like, look, these things are associated. We can have an effect on one side of that equation. If we change one side of that equation, there's going to be an equivalent on the other side of the equation, right? So it's not making bold claims. It's not saying that you can do things that you don't know if you can do. It's like, no, take that experience, take the things that you do know how to have an effect on, and then use those as tools in that experimental practice, and then see what kind of results you get, and be transparent about it. I don't know exactly what this is going to do, but I think this is going to have an effect on this. And if you can prove that to yourself, if you can prove that to them, that deepens that buy-in. Is that okay? He's being transparent in this process. And like, fuck, man, like I've been dealing with blood pressure issues. I've gone to a cardiologist, a vascular surgeon. Like I'm going and seeing different people, and you know what they do? They fucking guess. They're like, I'm gonna put you on the same drugs as this 65-year-old person, and we'll see if they work. I'll see you in a month. Oh, they didn't work. Let's try these drugs instead. Oh, like that's all it ever is. That's all it's ever going to be is, yes, we're going to use the information in front of you to make an educated guess. And if that doesn't work, then now that's information. And it's not like if it doesn't work, it's bad information. No, that's valuable information that, okay, we've now learned that everything that would be caused by this intervention or affected by this intervention is not going on. So now that gets us closer to a diagnosis. So every no is closer to a yes in this case. That's exactly what we're trying to do, is we're trying to eliminate things. And that, okay, like if we do a shotgun approach and nothing's working, it's like, all right, it's probably none of these shotgun causes, like none of these, broad spectrum variables. So that only leaves us with like 4 things that we need to sort between. And then you start to figure out, okay, this is specific to thing 1 and thing 2, but not thing 3 and thing 4. And now, okay, we're down to 2 answers. So it really very much is that process of trial and error. But I think a lot of times people feel like they need to have it figured out. But it's kind of a swing where people are coming to chiropractors and like physical medicine as like a preventative thing, which is cool. But a lot of times people end up there because they haven't had results with traditional medicine or the traditional medical system. So when they end up there, it's like, they've already tried a bunch of shit that didn't work, right? So it's not like they're just going to write you off completely if the first thing you do didn't work. But if you're transparent with them and you tell them like, hey, this may work, this may not work, but this is going to be part of our diagnostic process. This is part of our assessment. Then at least you're buying yourself some time to figure out what's going on. You're not setting this unrealistic expectation that I'm going to do this and you're going to feel this way. You're at least being transparent about that.
Well, the map thing I want to kind of dig into a little bit more, because when people are dealing with pain, you hope that most people aren't well seasoned in dealing with pain, at least from like a patient standpoint. Right? You hope that people live healthy lives and they don't run into issues, but it's going to happen every now and then. As a practitioner or as a coach or a clinician, what have you, you're uniquely experienced that everyone who comes into you has some sort of pain, especially if you're a clinician. So it's like you navigate this map a lot and you're dealing with people who don't, right? They're not used to this journey. And I can't help but think, when I was a kid, my parents would save up every single year. We go on one trip, and the car that we would drive, whatever the family vehicle was at the time that my dad got from like a junkyard, was never up for the trip, because we would go skiing in Vermont and we would drive 17 hours straight to get there because we couldn't afford flights. But what my dad would do is he would rent a car that was worthy of the, whatever the turnaround on that 30 plus hour trip was. And I remember once, do you remember the Ford Taurus station wagons that had seats that faced out the trunk? Nothing says you don't want to talk to your kids like putting them in the trunk and giving them motion sickness for 30 something hours. And it's like, whatever, we got it. We were so excited that we got to go on a vacation. But like, I remember that trip being the epitome of, are we fucking there yet? Right? Like, you're in the trunk throwing up whatever sandwich your mom made for you 2 days ago. And you're just like, get me the fuck out of this goddamn trunk. And I think of that a lot in the way that people communicate from a patient's perspective, this journey, this roadmap. It's like, oh, you haven't, like, now the idea of a 17-hour car ride is peaceful. Oh my God.
Dude, I feel that's
dude,
so
when I
fun.
fucking when I drove back from Miami, I had like 28 hours in the car, and I was just like, oh, Oh, that's just
Yeah.
the thought of just being able to sit in my own thoughts for 20 plus hours straight is just, I mean, that's like, monks will sit in solitary confinement and so will a prisoner. Only one of them lose their minds and another one becomes enlightened. And it's just like, as a kid who, without experience, you're fucking dying back there, dog. But as a grown ass adult, hopefully, if you're well adjusted, that idea is like, there's some peace that comes with that. When you're the person who's, driven those roads 1,000 times, you have an obligation to like, all right, do we need to take like a rest stop? Do we need to, the kids are getting antsy. Hey, maybe they're just hungry. They don't know that they're hungry. They're just fucking acting up. So it's like, there's A to B, and there's this there's this journey that you take people on, but there's so many pit stops and pitfalls around the way, on the way, and it's like it's not easy because you're not taking a train. It's not on the tracks, right? This thing is a Ford Taurus station wagon when you got them facing backwards, and sometimes they're going to throw up, and sometimes they're going to get tired, and sometimes they're going to fuck. And you got to be able to like, all right, where are the bends in the road where this is going to be an issue? Where or when? All right, how long since So the artfulness, knowing the road is so important.
And we're back, ladies and gentlemen. Shallow had to drop out mid roadmap analogy. But I mean, the idea here is that essentially what you're doing is you're outlining the process, right? You're saying this is how we get from point A to point B. And as we go through this route, there may be things that need to change. If there's traffic on 101, we might need to take 280. If you can't progress your stationary lunge, we might need external support. And you're outlining this process for someone that they haven't been there before. They don't understand. They don't know what it's going to be. They don't know what to expect. So the more that you can make this a gradual adaptation for them, the more you can show them like, no, this is what we should be feeling. And there are unwelcome sensations as we go down this route of chasing pain and sorting it out. But it is for the better. That's for you to interpret. That's not for them to know. So, I mean, a little bit more theoretical in this episode, but the idea is that the more that you can build your experience around getting positive outcomes, the better you're going to be for it, because then you can communicate that better. And the better you can communicate, the more you'll be able to refine your practice of understanding pain, understanding diagnostics, understanding intervention. And that's just going to give you more practice that the first time you do something, it's never going to be great. It's hopefully the worst you will ever do it. And then the next time, with a bit of assessment, you can do it better and better and better. And then the more routine these things are, the more things that you see, then that just makes you more accurate at getting outcomes against more variables. And that's what it is as you get into practice. But the biggest thing is that you need to have that experience. And the only way you're going to be able to get that is being confident enough to have that humility and understand what you don't know. And if you can have that relationship, if you can build that trust with your clients, then they're going to keep coming back. And that's going to allow you to refine that skill time after time after time. So I don't want to listen to myself talk anymore here, but thank you for tuning in. Again, we have the level 1 going live in just a couple weeks here. So if you guys are interested, www.pre-grip.com. That is accredited through PACE for, I believe, 16 hours of CEUs for chiropractic. We also have continuing education hours for ACE, NASM, and a CA. So if you guys have any questions, hit us at info@pre-grip.com. But thanks for listening. We'll talk to you guys soon.